Gamhevage, consultant, and I'm a senior lecturer in Paediatrics. And on behalf of Sri Lanka College of Paediatricians, I warmly welcome you to this webinar on overcoming challenges in breastfeeding. So, as all of us are aware, we celebrated the World Breastfeeding Week in the first week of August, and this year's theme is Breastfeeding Support for All. So, we are organizing this webinar so that we can fill in the gaps in our knowledge and we can ensure that we reach out all the layers of our community and make sure all our mothers are supported so that the newborns will be benefited by exclusive breastfeeding techniques. So today we have a brilliant group of resource persons with us, Professor Gita Sathiadas, Professor of Pediatrics, joining us from Jaffna. She's the Professor of Pediatrics, Chair Professor in the Jaffna faculty, in the Faculty of Medical Sciences, Department of Pediatrics. And we have Dr. Nishani Lucus, who is a consultant neonatologist and also a senior lecturer in pediatrics at Faculty of Medicine, Colombo. And Dr. Himali Herath is joining us from Family Health Bureau. She's the National Program Manager of Intranatal and Newborn Care. And we also welcome Dr. Sathika Amarasekara, consultant neonatologist at Nuwara. We welcome all of you for this webinar. So to begin the webinar today, I would like to invite Dr. Himali Herath to briefly discuss about the current breastfeeding situation in the country. Dr. Himali, over to you.
Thank you, Dr. Nimesha. And I would like to thank the Sri Lanka College of Pediatricians for organizing this important event during the breastfeeding month. So I'll briefly talk about the current breastfeeding situation in Sri Lanka. Next slide, please. Yeah. So these are our breastfeeding rates based on the Demographic and Health Survey data 2016. That is the latest available DHS. So 99.4% of our newborns are ever breastfed, and 90% over 90% initiate it at 6 months is 82%, and we have median duration of breastfeeding, that is 30 months. So breastfeeding is one thing as a country we are really proud of. The next slide, please. And there's a ranking system with regard to breastfeeding. So then globally, the World Breastfeeding Trend Initiative, they rank the countries based on their program and policies with regard to support breastfeeding, as well as considering the important practices regarding breastfeeding. So, and in 2018, when Sri Lanka had our assessment, Sri Lanka became the first country to achieve the green status out of the 97 countries, and then became the first ranked #1 or the ranked first in the whole world with regard to breastfeeding. And in 2021, the Bangladesh did their assessment, and then they scored 0.5 marks ahead of us, and they became the world #1. And with regard to breastfeeding, now Sri Lanka is ranked #2. But we scored very high on program and policies with regard to breastfeeding. But as you can see our report card on the right side, you see there's one circle in red. So that is one of the practices they mark us for, that is the bottle feeding rate. So 36% of bottle feeding rate happening in a country which is world best for breastfeeding. So this is a very important practice that we have to discourage and discontinue. So it, like when they further inquired, it is not the infant formula that they have given in the majority of cases, but even the extra breast milk they have given use in the bottle. So as healthcare workers, we have to be very vigilant and bad practice. Next slide, please. Next slide. Yeah. So there's a cost of not breastfeeding tool that is developed by Alive Thrive and the Nutrition International. That is to show the countries and the health workers. So the cost of not breastfeeding is huge. So if we take at the current breastfeeding rate in Sri Lanka, so which is considered as one of the best rates in the world. So they have done these calculation and the estimates based on the three indicators. Like one thing is exclusive breastfeeding rate, and then continued breastfeeding rate at 20 to 23 months, and early initiation of breastfeeding. So I'm sorry, it's not very clear, I think. And then these rates are a bit different from the rates that I have told you before. That is because these exclusive breastfeeding rate, they have got it from some UNICEF estimates. Okay, and then even with that, they estimate Sri Lanka as the world #1 with regard to breastfeeding. So the next slide, please. So then you know that our rates are very high, but still, so there's a huge cost incurred by not breastfeeding. We know that 80 to 82% children are exclusive breastfed for 6 months, but there are 18% who are not exclusive breastfed, and there are 10% who are not initiating early initiation within 1 hour. So due to that, we have to pay a huge cost. That the cost is from the health consequences perspective and also the human capital, economic, and so then if you consider the health consequences, we already know that the morbidity and mortality, not only for the child, but also for the mother from breast cancer and ovarian cancer. So these are the estimates. So I invite you all to go and have a look. That's available online. And then there's a human capital lost as well. So how many IQ points we are losing as a country, as a nation, due to not breastfeeding? The one cost, you already know that breast milk substitute or the infant formula cost. Previous slide, please. Okay. Yeah. So then that is one thing that everybody knows, but it is very, very minimal when you consider the health consequences, human capital, and economic cost as a nation. For example, each year for the economic cost, it's 122.9 million USD per year. That we are losing due to non-breastfeeding. That is through early deaths, morbidity, mortality, and health system cost. And the same way IQ point losses, so then that cost of not breastfeeding is huge. The next slide, please. The next slide, yeah. So in 1 minute, I'll just describe the Sri Lanka has a very unique model to support, protect, promote, and support breastfeeding. So we have continuum of interconnected, community-based, and hospital-based care across the life cycle and across different health systems for protecting, promoting, and supporting breastfeeding. So we know that there are 360 MOH officers and providing home-based care through the midwife, and also they have the field antenatal care, child welfare clinics, supporting breastfeeding in the community level. And then we have the non-specialist hospital, 460 across the country, providing the first level health facility care, then again supporting breastfeeding. And then we have 114 referral hospitals where we have the consultants. Okay, next slide, please. So this is very briefly the life cycle approach for promoting, protecting, and supporting breastfeeding throughout the life cycle, starting from the hospital. You know that all of our specialist hospital, they have to be baby-friendly hospital initiative. They have to implement the 10 steps for successful breastfeeding, and then initiate breastfeeding within 1 hour. So then followed by even the breastfeeding support in the postnatal wards, NICUs, school boost, and there are lactation management centers to support mothers with breastfeeding concerns, and we have the mother baby centers in the hospital. So then it is linked with the community service with the midwife at the time of discharge. So then providing home-based postnatal support to provide, to give the support for breastfeeding. And then we also have the mother support groups in the field at the community level supporting it. And then, so there are child welfare clinics integrated with the immunization. So each and every visit to the child welfare clinic, so the mother is encouraged and praised for breastfeeding and supported if she needs any support. And then breastfeeding is included in the school curriculum. And when the girl child, when she gets married and then become pregnant, so then the care is continued through the community and also through the hospital setting. Next slide, please. Yeah, so this is my last slide. So I wanted to show you and thank all of you for this contribution, because like 25 years ago, that is 30 years ago in 1993, we had 19% exclusive breastfeeding rate for 4 months. See the achievement, that is after 25 years in 2016, it is 82%. So it is more than 4 times increase in exclusive breastfeeding rate. Thanks to all of you. As part of your everyday care of the patients, we all have contributed to this high rate, and we all want to have improve it further and also to sustain the achievement. With that, I will wind up. Thank you very much.
Thank you very much, Dr. Himali, for sharing all these inputs and data with us today. It was very comprehensive. And I mean, as hospital staff also, I think we can do better definitely, because looking at the early initiation of breastfeeding of 90% is something we can work on. I'm sure about that. And also at the community level as well. Most likely we can do better than this. Thanks a lot again, Dr. Himali. And next, I would like to invite Dr. Nishani Lucas to share her knowledge with us today. And my first question to you, madam, is what is on-demand breastfeeding?
Okay, thank you, Nimesha. So on-demand breastfeeding is basically where we follow the hunger cues of the baby, right? So we have to know whether the baby is hungry or not. When the baby is hungry, we need to support the baby to breastfeed. So that is what we actually mean by on-demand. So the demand is actually coming from the baby. Does that answer your question? So hunger cues would mean where the baby is looking around, putting the hands in the mouth, basically indicating when the baby is hungry. So this should be started soon at the time of birth itself. So when the baby is born, you know, the principle is we need to support the baby to feed from the breast within the first hour, because otherwise the baby will fall asleep. So even at that time, some babies, as soon as they are born, they will be looking around to feed. So those guys straight away put to the breast. Some babies want to sort of, you know, be at peace for a while, and then only they will want to latch on to the breast. So wait for the hunger cues. So these hunger cues will be there even until the time of sort of, you know, complementary feeding. It's important to follow the baby.
So most of the mothers, they get confused about this concept. They keep on asking, okay, doctor, my baby sleeps like 4 hours in the night. What am I supposed to do? Am I supposed to wake him up in 3 hours or 2 hours time? What should be the answer, madam?
So what we need to know. So the short answer is no, you should not wake them up. You have to wait for the baby to wake up. And if the baby wakes up, then you feed. And then we also have to explain, we can't give a time limit saying you have to feed every 2 hours or 3 hours or 4 hours, simply because now milk is coming from the mother and the amount of milk that comes is going to vary. Right, so because now sometimes like milk also is produced in the sort of a circadian rhythm. Maximum milk production is around 3 a.m. in the morning. So minimum is in the evening. So at different times of the day, amount of milk produced is different. So baby will drink different amounts of milk. So if they drink only a little milk, then they will get hungry soon. If they drink a lot, they will sleep for a couple of hours. So if they are sleeping for 3, 4, 5 hours, that is fine, because even for us, we can't exactly put a rule and say this amount of time. So for preterm babies, what we say is, yes, please have a look to see that the baby is breathing and pink and all that. But don't wake the baby up. Don't try to wake the baby and feed the baby, because then baby gets annoyed. It's just like us, someone tries to wake us up from a blissful sleep and we get really irritated. So like that, we should not wake the baby up to feed, but wait for the baby to wake up. Also, in saying that every half an hour, if the baby is trying to feed, that means also there's a problem. Because babies usually get hungry every, say, it can range from start off from about 1.5 hours to 2 to 3. And it will slowly, the gap should become longer, because baby's stomach is the size of like a cherry on day 1. And it's like an egg by 1 month. So small stomach. But capacity will slowly increase. Skill of breastfeeding increases. So quickly they will empty the breast, and they should remain full for a longer time when they are able to extract more breast milk. So if they are sort of waking up every 1.5 to 2 hours soon after birth, it should be sort of 2 to 3 hours when they are about 2, 3 months. Then about by the time we want to start food, like say between 4 to 6 months, it should be around 3 to 4 hours. So those are it would be the breast milk times that we should actually go and substitute with the food when we are starting complementary feeding, and then the baby will have a nice schedule. I'm hoping I answered your question. So you need to actually individualize it and explain to the mother that the amount of milk that is produced at different times will vary.
Yes, madam. Yes, that was helpful. So now I will take you. I will take you through some of the common situations where actually mothers get very disheartened and discouraged, and I think these are the main situations where mothers, get forced to start formula feeds, or express and put the milk into a bottle and feed via bottle. So one situation is this inverted nipples. So how can we handle this situation effectively?
Okay, so I think one of the first things is now inverted nipples. This sort of patient, before we discharge from the postnatal ward, should have been identified as a mother who is at risk, who's going to have a problem with breastfeeding. Right, so there is no place to antenatally check the nipples and try to pull it out with syringes. Pulling out with syringes is barbaric and should not be done. Although it is in the book, it is not useful and it's quite humiliating for the mother. So no longer recommended. But once the baby is born, and if you see now, each baby, to start a little bit before this, before we discharge, every baby should be checked as to the breastfeeding technique. So each baby, there should be documentary evidence that breastfeeding technique has been checked and is satisfactory before discharge. And also we should check, now we know it is now the policy to check the discharge weight as well. There's a place in the CHDR. So check the discharge weight, check what percentage of weight loss has happened within the first 24 to 48 hours. If it's more than 5%, that means feeding is generally not very good, needs more support. Then the next day you check again, check along with the breastfeeding technique. So like this, you should have picked it up from the hospital itself. When it's picked up, these are the kind of ladies who we have to admit to the mother baby unit or PBU or wherever it is that we can give one-to-one support. So if you have a mother baby unit, that is the place. If you don't have a mother baby unit, like in our hospital, we admit to our feeding side and we give one-to-one support. So there is no place for using bottles, no formula, because now what happens is when the baby exerts negative pressure with correct attachment, this inverted nipple starts coming out little by little. So in 3-4 days, it actually it may be 3-4 depending on how good the amount of effort you put, or 4-5 days, the thing will start coming out and it will gradually become more easier. So until that time, sometimes bad experience, poor skilled support in the beginning might lead the baby to breast refusal, in which case we might have to express and give by cup. So that is another thing. Even if they are expressing, we have to teach all these things from the place where baby is born before we discharge, rather than allow the mothers to go and sort of, get influenced by the media, social media, whatever, which is giving a lot of wrong information. So even with the inverted nipple, you have to be patient. That is the important message. So whereas a normal mother maybe sort of, may get this in 2-3 days, maybe for a mother with an inverted nipple, it might take slightly longer, maybe 4-5 days. So that is the sacrifice we have to make. So, but with that, baby will benefit a lot rather than being hasty and trying to start formula. So it works. We do this all the time in our hospital and we have achieved 100% success for inverted nipples.
And for the audience, if you have any questions, you can put it up in the chat. You can use any language that you like. And also you can raise your hand. There is this thing for that, and ask your concerns or questions then and there. And next issue is engorged breast. Still we see various types of advices being given to mothers, and sometimes with these advices actually the problem gets worsened. So madam, what is the proper way of managing this type of engorged breast milk situation?
Okay, thank you, Nimesha, for that question. Again, it's a very important one, like the previous one you asked, and not so uncommon as well. So I think let's take a minute and think about why does the breast get engorged? That will help us to think what we should do. So why the breast gets engorged is because milk is produced. So there is no problem of production here, but milk is not emptied well. Right, so this means why won't the milk be emptied? Because attachment is obviously having some issue. So we need the root cause of the engorgement is root cause of the engorgement is poor attachment. So we need to correct that. But meanwhile, this is also a very painful thing for the mother. So in order to relieve the pain, mother can use a pain relief, as well as we can advise her to use a cold compress after feeds, meaning she can dip a sponge cloth in cold water and sort of, keep it on the breast, or maybe have cabbage leaves which are in the fridge, whatever, that will cause vasoconstriction after she feeds. So feeding also should be only until the breast feeds light and the baby is happy, and not for long durations, because we must remember the more we empty the breast, the more milk is produced. So expressing breast milk in a person who is engorged should not be done unless the mother says she can't breathe, or around the areola area is so hard that the baby won't attach at all. So we should not express and try to empty the breast, because that will just make the engorgement go on for longer and long. So just attach, allow the baby to suckle directly from the breast until the baby is full for about 10-15 minutes. When the baby pulls off the first time, we would not put the baby back again. Then hot compression is something that has been there in the past, but what it actually does is, one is the skin over the breast is very thin. So there is very high chance of damage and injury to the breast, so it should not be done. And second, with the increased vasodilation, the edema fluid increases, so the edema becomes worse. So hot compression again shouldn't be done. Unless, of course, the very rare instances like the breast is really, really hard, and even when you try to express and the baby refuses to go to the breast because it's rock hard, you try to do it with the hand to sort of soften the area around the areola, still nothing happens. In that case, maybe very slight hot water compression around the areola might be needed, but that is very, very rare. So generally, no hot water compression, no expression of breast milk. And if we are massaging, unlike massaging towards the nipple, we should massage away from the nipple. It should be towards the axilla, because this is where the lymphatic ducts that drain the breast are. So we have to massage towards the axilla. So I think those are the important things with regard to engorgement.
Yeah. And madam, there is one question coming from the audience, whether we can use a nipple shield when mothers are having inverted nipples.
Yeah, nipple shields there is no recommendation to use nipple shields other than from the manufacturers of it. Right? The reason being that you pulling it from the outside is not going to help. That is what you need to understand. Right? And the problem of the nipple shield is, like, nipple shield is another foreign object which is plastic, and in the first couple of days only little bit of milk is coming. That also is a bit challenged because without the proper attachment, the flow it will be a bit slow to get the milk flow. So the 1 or 2 drops that are produced is likely to fall between the nipple shield and the skin. So more risk of infection, more risk of losing that milk as well. So no, you do not need a nipple shield. You need to attach the baby onto the mother's breast straight away. That is a much better method. So nipple shields are not recommended, although people frequently use it.
Yeah. And then again, there's a question whether underarm breastfeeding method is better when there are inverted nipples.
Yes, sometimes it may be useful. It will depend, especially people with a large breast. Underarm method is very useful. And even sometimes for mastitis, because sometimes now, like, the breast is like a sphere, the way we are holding and the way we are used to hold the baby, sometimes the whole sphere doesn't get emptied. So some parts are like, some milk is left and it tends to get infected, causing mastitis. Even for mastitis, underarm method is very helpful. Yes, we can't say you need to do underarm method for every baby, but in many instances, it is very helpful.
So it's quite individualized, so that you have
It's
to
quite
work.
individualized, Nimesh, and especially for twins and all. Anyway, we have to use underarm because we have to use both. We have to feed both babies at the same time when we have sort of, when mother is familiarized with feeding one baby.
Yeah. So it's very good when the questions are coming from the audience so that we can discuss about it. And the next one is the commonest complaint we get from the mothers: I haven't got enough milk. How are we to tackle this as a healthcare professional?
Okay, so thank you, Nimesh. Excellent question. So before this, can I just answer? There was another question on inverted nipple and antenatal care. So antenatal care, actually, we shouldn't be looking at women's breasts to look at nipples because it's very demoralizing for the woman. Like, you and I don't like somebody else looking at our body and saying this part is ugly or whatever. There's nothing you can do about it. So therefore, no, there is no place for checking it antenatally because you can't do anything, right? So when I ask the midwives, what they say is they check to see whether there are lumps for breast cancer. So if that's the reason you're checking self-examination, fine. But checking for nipples, even if it is there, we have to tell that, it's okay whether you have a flat nipple or inverted nipple. Only thing is it might take a couple of days more to establish feeding, but you can do it. So that is the answer. Antenatal care, you should not be looking at nipples, pulling it out with syringes, hand, or any other device. Then coming to the question of I haven't got enough milk, it's a very common complaint, and I think even all of us would have felt it, those who have breastfed our babies, if you have gone to that stage, because the first couple of days you get only a bit of milk, and even the breast doesn't really change that much. It just feels the same like just before you delivered. So there are a couple of things we need to do. First, we have to see actually is there a inadequacy of milk, or is this something a subjective feeling that mom is having? So either way, we need to counsel the mother. So if the reason is now, say for that, what we have to check is we have to check the birth weight and we have to check the current weight, right? So if we check the birth weight, and we check the percentage loss, as I mentioned. So let's say 3 kilogram baby comes, the weight is 2,900 when the mother comes to us. So only 100 gram loss, it's less than a 5% loss, right? So in that situation, it's very small loss. And you ask how is the urine output? So you should know the normal urine output. On day 1, it's once, day 2, twice, day 3, thrice. For more than 6 times urine output, it takes about 5 to 6 times a day, right? So if urine output is good, there is weight loss is minimal, less than 5% weight loss, or there's a weight gain happening now. That means, you can look at the breastfeeding technique. If those are good, that means there is no issue for the baby. Baby is receiving adequate milk. But you have to ask mother, so you have to explain all these to the mother. If it's a bigger child, use the growth chart and show how the weight is going along the growth trajectory. Explain to the mother how the milk is the only food baby is getting if she's exclusively breastfeeding, and that is what is linked to either not losing the weight or reduction of the weight loss or growing along the birth trajectory. And also, this is the only source of hydration, and to maintain urine output, this is the only thing. So you have to convince mother and explain to her that. Then you can go into it and see why she's thinking, although everything is okay, why is she thinking she doesn't have milk? Maybe some mothers get scared because baby is passing urine. Every time she is feeding, baby is passing urine. So she thinks all the milk she fed has come out. Sometimes every time she feeds, baby is passing stool. Again, mothers think everything has come out. Sometimes baby may be crying from time to time, which has nothing to do with milk, because crying is a large area again. When baby wants to be held or when parents are nervous, for many reasons, babies start crying. So they have to talk about consoling, different reasons for crying, so many other things. And maybe the neighbor's child is like feeding every 2 hours. This one's child may be feeding every 3 hours. So she may be thinking her baby is not feeding that much. So there are many, many reasons why mothers think that they don't have enough milk. But actually, when you look at the weight, you see the weight is actually good. So that category we have to counsel and explain. Then there will be a category where there is actually a weight loss. So if there is a weight loss, what can happen is, if there is actually a weight loss, we need to check what is happening. So where it is going wrong, whether it is a positioning problem or an attachment problem, what has happened. So with that, we have to support and give the necessary skilled support. That is about not having enough milk, and if there is a problem, we have to check out whether it's a positioning is the issue or attachment is the issue, and give them the required support for that. Is that okay, Nimesha? I tried to tell it in as short as possible.
Yes, madam. So there are lots of questions coming up in the
I
chat.
kind of saw, yeah, I was getting distracted. Sorry.
I'll quickly go through them. If some multipara mothers having sagging breast, how can you latch the baby properly to the breast apart from underarm method?
Okay, I have 2 things I think I would like to add for that. One reason, okay, so now this is about multipara mothers, even primary mothers. Some people don't like to breastfeed, saying you lose the breast shape and the breast will start to sag. People don't talk about it a lot, but it's a question in a lot of people's minds, whether you will lose your figure, whether you will lose the breast shape. So actually, what happens is, it is very important to support the breast, because with the breastfeeding, the breast is going to get bigger. And with this, what will happen is, if you don't give it the proper support, breast will sag. So you need to make sure that mothers actually wear a proper sized bra for the new size breast, because when the lactating breast will be slightly bigger, or at least 2 sizes bigger than what it was during pregnancy. So that is a gradual process. So therefore, it is important to tell them to wear a proper size breast here, because there are some mothers who are of the impression that they should not wear a bra if they are lactating mothers, which is totally wrong. That is the recipe to get a sagging breast. So it is very important to wear a proper size bra. Of course, when you are feeding, it can be a feeding bra or whatever thing, but you may have to remove it or use a feeding bra to feed. For multipara mothers or mothers with sometimes a large breast, it's very important again to wear a well-fitting bra. Because all other times when you are not breastfeeding, the breast needs support because the breast has become large. And if you remember the anatomy, it has what are called Cooper ligaments. So the Cooper ligaments, we should not let them break. We have to support it. If we support it, we can maintain the breast shape, although breastfeeding also happens. So that is the recommendation, not only for the multipara, but even for a woman with large breasts. And even for primaries and for all mothers who are breastfeeding, you can keep your breast shape. although you breastfeed the baby, despite breastfeeding your baby.
Yeah. I think these points are very important when we are to talk to mothers and support them. Very important practical points. And there's another question on breast pumps. What is the recommendation for using breast pumps for mothers who have to use express breast milk to feed the baby?
So again, I do not recommend breast pumps. The reason being, hand is much more powerful and much more cleaner. Right now, the issue where the things don't come when you express with the hand is because the technique is wrong. Technique is frequently wrong. That is the issue. Problem with breast pumps are most of the pumps in the market, which are cheap and affordable, do not work. Even the expensive ones which do work, which are rather expensive, they have very small parts. Now, I remember one time my cousin called me and she had some problem with the breastfeeding. So without asking anyone, she has got the pump. You know how people are. And then to see, she said it's not working. This was an expensive one. And then to see, the most important part in that pump is like the size of a 1 rupee coin, very small part. That part she has not assembled. Then other part is there are all these small tubes and gadgets where you can't even put a toothbrush or any sort of brush inside, then clean. So chances of, because now its milk is a very nutritious media.
Yeah.
So therefore, again, chances of infection are high. So much easier thing is wash your hands, express the milk into a wide mouth cup, close the cup with a well-fitting lid, and your chances of infection are minimal. And every little drop that comes, you can take. Same thing like with the nipple shield. Because when we use a pump, there are some gadgets through which the milk has to go. So if only very little milk is coming, it will be lost. So therefore, actually, a mother who is expressing well can actually express as fast or faster than a breast pump. So poor technique is the thing that leads to breast pump. So pumping technique or the expression technique by hand, we need to learn. So what is frequently seen is people look at the cow and do the same thing. That doesn't work. Pulling forward just like the it's very, very different in the human.
Yes, exactly.
You have to keep your thumb and index finger 6 o'clock, 12 o'clock position, push back onto the rib cage. Count to 10. And then approximate thumb and index finger in the same plane. Don't bring it forward. Don't pull the breast forward, and none of this should hurt the mother. It should be comfortable for her. So important to adhere to the correct technique.
And also a very important question on how to improve the breast milk production in a mother whose baby is admitted to the NICU.
So those mothers, I think it's again a very good question. We have to start expressing, if we can start antenatally, that is the best. And I think some of us are already doing that. If not, as soon as they deliver and the mother is stable, we have to start expressing milk. So you can't give this responsibility to the mother herself, because mother herself will not mother herself will not be able to do it. So the staff has to actually help her to do this. So that is one. And so we send a 1 cc syringe because the amount of milk that comes is very small. Otherwise, the mother gets very discouraged when she sees 1 drop in a big cup. So you send a 1 cc syringe, remove the needle and take it to the hub of the syringe, and you transport it to the baby who is separated. Then you have to allow the mother to come and see the baby as soon as possible. If not, at least take a picture, go and show her, give her the updates, because she has to be motivated. And if she sees the baby or holds the baby, motivation is more. If she's in the ICU or she can't come for some reason, we should go talk to her and praise her for giving the breast milk, or encourage her to give some and give her updates, and try to get her to come see the baby even in a wheelchair. When she comes, get the wheelchair inside, get her to touch the baby even if the baby is ventilated. If not, prolonged kangaroo mother care as long as we can.
So those are the main things, and expression in the ward should happen every 2 hourly. So at least for 15-20 minutes. But the rest of the time we have to specify to the mother, she has to take a break. She can wash or read or do what she wants, because some mothers, they adhere to our word so much, they continuously express through the 2 hours into the next 2 hours. Then she won't get a break. So she needs to be healthy as well. And therefore, like, get her to express every 2 hours or so, and the staff has to help, especially the first couple of days. Initially, staff should help and express, even if nothing is coming, express for 20 minutes, because then the breast will start getting wet, and slowly 1 or 2 drops will come. So however sick the mother is, actually this can be done, provided, mother's physicians tell not to breastfeed. So yeah, those are, I think, most of the things. And to continue the breastfeeding in the night. Now the staff in the hospital doesn't like to bring the mothers in the night to the unit. But that should not be allowed, right? So if she is tired, she can sleep early evening from say 6 to 10 p.m. or whatever, or early morning. But that night time, prolactin peak is between around 3 a.m. So we must get the mother down sometime during that time to feed the baby. So now continuing night feeds, expressing regularly 2 hourly or so for 15-20 minutes, then supporting mother health, self-care for her. And many mothers get upset with the birth of a preterm, because they may not expect, and when they see the baby is not what they expect to be. So psychological support is important, referring to a psychologist or psychiatrist for counseling, getting her family to sort of, she needs to feel valued, us talking to her and praising her when she comes in for giving the milk, regular updates, getting her to touch the baby, kangaroo mother care. So I think there are lots of things we can do. And if we keep at it without giving up, you will definitely succeed.
Yeah. Thank you very much, madam, for sharing your experiences with us. I think those tips are very important for us to improve our practice in our hospitals as well. So my next question is for Professor Sathiadas. Madam, how can we support mothers who are going to work? I think this will be this is a challenging situation for most of the mothers, and most of the time this is a time period that they fall on to start formula as well. So how can we support our mothers in this situation?
Thank you, Nimesha. I think because of the socio-economic burden and a lot of issues, prices going up, both parents are ending up working. So most of our mothers are now working. So you can see that is a problem for breastfeeding as well. And I think there is a regulation in Sri Lanka which allows women who are working the breastfeeding ordinances. So if you can share that slide where yes. So if you see, there are 3 ordinances that are covered for helping women who are employed on breastfeeding, especially in Sri Lanka. One is the maternity benefit ordinance. The other one is called the public administration circular, and then there is another one for shop and office employees. So this is basically based on the government employees, the semi-government employees, and the other one is for private or like kind of small establishments. So if you look at all these circulars, all of them which have been amended periodically allow 84 working days for women to take leave, and that is paid leave as well. So you can take the leave depending on how much you want to take. So sometimes you may take the 2 weeks before your confinement and the 6 weeks or the 8 weeks later on. But it depends. Whenever you are going to start your leave, you just inform your superior officer, and from that day onwards, you can take the 84 working days. Now, for example, the 84 working days that is there in all categories of women, it includes the weekends, public holidays, and everything that is also there. So it doesn't count the weekends, public holidays. It's the 84 working days. or when you take in government sector, especially the public administration circular where it involves government employees, the circular is slightly changed. You can take half pay leave for another 84 days. In that situation, it doesn't count it counts the weekends and the poor days. And then following the half pay leave, they can also take no pay for another 84 days. So that comes to roughly about 1 year. When the child becomes 1 year, the mother is there for the child to grow and to help him or her in the nutrition aspect. When you don't have this half pay, no pay leave allowances, that is the non-governmental and the small business establishment and private establishment, the 84 working day rule is there. But after that you are allowed a nursing time. So the nursing time also depends on the timing you are taking. The first few months or 5 months after you take your maternity leave, you can take half an hour breaks for feeding. So that means the mother can go and take break during a 9-hour shift. She can take 2 hours of nursing, 2 nursing intervals, 30 minutes each she can take, or if it is beyond that, half an hour she can come late for work and go early for work. Some of these establishments which have a lot of women working, say for example the garment factories and so on, where there are a lot of women, these establishments may have childcare, the creche you call it, the childcare facilities, where the children, the babies are kept in these in these places, and the mother works and then she can go feed the child and come back. So these are some of the benefits that we have in Sri Lanka, where you can take maternity leave, half pay, no pay, especially in the government sector, and the feeding time, nursing time is also allowed. So if this is not possible, then you can actually express the milk and store it and reuse it in other situations. Now, can I talk about that as well, Nimesha?
Yes, madam. Yes, madam. Actually, there was a question also in the
That's
chat
what I
box
thought I should
regarding.
talk
Yes,
about it.
yes,
Yes. So now when women express breast milk, I think a valid point was raised by Nishani when she said not to use the breast pump because of the sterility issue. That is a very valid point. When you're trying to express breast milk, that is the key important aspect that mothers should be worried about is the sterility. When you directly feed the breast milk, it doesn't come into a problem. But you have to, when you're expressing, the most important part is washing your hands thoroughly with soap and water, having a clean container. Clean container washed with soap and water. Doesn't have to be really a sterile container, but preferably a clean container without any contamination. You should have it. Sometimes we try to say that when you're storing these breast milk, preferably you have to use a glass or a plastic containers with tight lids. But there are bags that we can use, specially made bags to store breast milk. But the problem is when you are using these Ziplocs or bags that are usually used to store food, do not use those things because of the sterility problem. So that is not the correct way to use storing of these breast milk. So if you are using preferably a glass container or even the bottle, the glass container or a plastic container you can use. The storing, now when you're storing this milk, there are 3 ways you can store the milk. One is when you have freshly expressed milk, how can you store it? The first important part is when you're keeping it, expressing it and keeping it outside on a countertop or kitchen surface, you can keep it for 4 hours. If it's the refrigerator, that is 4 degrees, you can keep it for about 4 days. If you're freezing, that is in the top compartment in minus 18 degrees or even colder than that, you can freeze it preferably up to 6 months, but you can go on up to 1 year. When you're refrigerating, you have to make sure you do not store it on the door. Door is always open and closed. The temperature varies on the door and it can get spoiled. So you have to keep it on the shelf that is just below the freezer, deep inside the refrigerator only. You have to keep the expressed breast milk for 4 hours. You can keep it in the refrigerator. Now, if you've frozen the milk, you have to take it out and thaw it. Now, previously frozen milk, when you have thawed it, you can keep it for about 1 to 2 hours on the countertop. You can, for 24 hours, you can keep it in the refrigerator, the thawed milk. But you should never refreeze the thawed milk, never ever refreeze it back into the freezer. And if you have leftover milk, you have thawed it or you have got express milk and the baby had drunk the milk, and if it is leftover, you can only keep it for 2 hours. Beyond that, I think it doesn't say in our regulations, it doesn't say to go beyond 2 hours. So hopefully I have covered most of it. And if you are using, never use microwaves or never use saucepan and direct heat to thaw the milk. You have to leave it, or you run it on hot water where the pipe, you open the tap and you run it in water, or in a warm water container you can put it and thaw it, but never boil or never use the microwave to reheat the milk. So that is the one of the other important thing I wanted to tell you all is refreezing and not to use the microwave. And when you're storing these milk also, always put the date, label and keep it so that you, when you're reusing it, you take the oldest milk and reuse it or thaw it when you're freezing these milk. I hope I have touched the questions that have been, don't keep
Yes, madam. I think that was very helpful. And also, if you could also explain to us regarding starting weaning solids in mothers who are waiting to go to work, what stage we can start the solids at the earliest, and little tips on that, that will be helpful, I think.
Yeah, I think exclusive breastfeeding up to end of 6 months is what the WHO recommends, and you should go up to 2 years is what the recommendations is based on the weight gain. Now, if you think the weight is getting into a problem and the mother has to return to work, then definitely you can start by the end of 4 months. You can consider starting complementary feeding, provided the weight is fluctuating. If the child is gaining weight and it's not having an issue, just continue up to 6 months is the rule.
Yeah. Oh, thank you very much, madam. So next we invite Dr. Sathika to share her experiences, which she has been working at Nuwara Hospital for some time now. So Sathika, what are the main challenges that you face regarding maintenance of exclusive breastfeeding in the state sector?
Thank you, Nimesha, and thank you very much for College of Pediatricians for this excellent timely discussion. Now, during the past 1.5 years, I have noticed several challenges. Out of that, 3 main things are poor maternal education. So most of these mothers in the estate, almost all mothers are estate laborers, or some are housewives, and their education level is minimum. So therefore, their understanding about advantages of breastfeeding are very minimum. And when you talk to this when we talk to these mothers, some mothers easily like with feeding, they have a lot of issues, and when we try to discuss regarding the advantages of breastfeeding to baby and mother, only thing they know is only about the nutrition that milk is going to when the baby is getting nutrition which give to provide the baby. All the other benefits, they are not aware about that. Therefore, it's really difficult to understand them, the importance of breastfeeding. On the other hand, their poor financial status have made them to leave for the work pretty early. Sometimes they leave, they want to start working starting from 3 months, 4 months. Sometimes only the mother is the only breadwinner of the family. Therefore, they have to work, and so they are the breadwinner for other kids and grandparents even. And the other problem which I have noted was benefits that they are getting from various NGOs at estate sector, where they get money and sometimes formula milk. These are not infant formulas. Most commonly, these are anchor or some kind of milk powder. And even during the ward stay, we have seen some mothers feed these babies with other type of milk.
Okay. So now, how do what? So we have. What are the situations that predispose these mothers to start formula feeds, Sathika?
As Nishani madam mentioned earlier, most mothers complain that they have insufficient milk supply, especially when they are twins. And the other thing is they have to leave for the work. I really don't know, even though we have a lot of laws to support breastfeeding for 6 months duration, even teachers and some other staff, which clerical staff, they start working from 4 months onward, and therefore they are unable to continue breastfeeding till 6 months of age. As I mentioned before, poor education is another problem. Young mothers, especially these young mothers, tend to commence formula feeds early. And they find it very easy to feed the baby with a bottle rather than feeding with the breast, as it needs a lot of technique, and they need to learn. Here in this area, there are a lot of young mothers or teenage mothers, and these mothers, especially when we review them at the clinic with the poor weight gain, first thing they ask is for formula feed. The other problem is, if there's a baby who has been fed with formula earlier, for this baby, it's really hard to convince them to continue with breastfeeding. Of course, adopted babies need formula feed. I don't think this is relevant to this feed, but I just mentioned.
Okay, yeah. And you already mentioned us about the poor weight gain. I mean, this is a problem that we encounter in our day-to-day practice. A lot of babies being referred to us to the well baby clinics. So how would you tackle this situation? How would you manage babies who are being exclusively breastfed having a poor weight gain?
Here I would like to discuss the 3 main causes for poor weight gain. The commonest cause is inadequate calorie intake due to insufficient milk supply or insufficient milk transfer from mother to the baby. And other less common situations are medical conditions of the baby and maternal, medical, and social issues. Next slide, please.
Yeah.
Now, here I have mentioned commonest medical causes for poor weight gain. Now, if the baby is anemic due to various reasons, and if there's excessive sodium loss in case of preterm babies and low birth weight babies, the baby is having high energy expenditure due to sepsis, thyrotoxicosis, or seizures, can have poor weight gain. Apart from that, especially in this area, babies tend to become cold very easily. And also here babies are about 28% of the babies are low birth weight. These babies tend to become cold very easily during bathing or excessive handling or due to inadequate clothing. Apart from that, other medical conditions such as GOR, hypertrophic pyloric stenosis can also cause poor weight gain in these babies. Now, when it comes to management, we need to take, as in all the other patients, we need to take thorough history, and then we have to perform thorough physical examination of the baby. The history should include, first thing is feeding technique, and we need to make sure baby is getting enough volume of milk during day and night. Then we have to assess whether baby is passing enough urine by assessing number of wet nappies per day, as Lucas madam mentioned earlier. Then examination should direct to assess whether there is any underlying syndromic causes or cleft palate or any evidence of underlying structural abnormalities which can cause poor weight gain. Then most importantly, the commonest cause is poor feeding technique, as Nishani madam mentioned earlier, where assessment of the feeding technique is extremely important. We have to ask mother to demonstrate the feeding technique, positioning and attachment. Then maternal breast conditions, of course, we need to assess. Then the management or interventions depend on the underlying etiology which we find during our assessment. So most of the situations which we have seen, as we all experience, correcting the proper technique, we can rectify the things. Therefore, we need to assess the assessment. Of course, we can do as outpatients or inpatients, depending on the maternal understanding or the severity of the baby's weight loss. And then if the feeding technique is good, then we have to investigate for other medical conditions, which I mentioned earlier. And if the mother is having mental postpartum depression or any mental issues or medical conditions, we need to refer mother to appropriate service.
Okay. Thank you very much, Sathika. That was very comprehensive. So I think we have come to the end of our webinar. It's 1:30 already, but there are a lot of questions coming up in the chat, which we have been trying to answer individually, all the resource persons. Just a couple of few more myths that is running in our heads. Sometimes we hear from pregnant mothers that somebody has advised them, you should not be breastfeeding when they are pregnant. I would like to ask Prof. Geeta Sathiadas whether there is any basis behind this. Should she be stopping the breastfeeding when she is pregnant, or can she continue it without any issue at all?
Or they can continue breastfeeding without any issue. Sometimes, very rarely, you may have to ask your consultant obstetrician regarding continuing breastfeeding, especially if there is multiple miscarriages in the past or preterm delivery. But other than that, there is no contraindication at all to breastfeed while you are pregnant.
Yeah, and the other common question sometimes is when the mother perceives as she's having, low milk supply, or when we see a poor weight gain in the baby, they sometimes come and ask you whether, I have a sister who is breastfeeding another, let's say 6-month-old baby. Can I get my sister to breastfeed my baby as well? So how should we advise them? Is it allowed? Is it not recommended? So what do you think, madam?
I think you can, I suppose, maybe a better person is Nishani.
Nishani madam, are you still there with us?
Yeah, Nimesha. Okay, so it's like this. If this actually happens sometimes, and it's a definitely better option than trying to go for formula milk. So what we have to say is, when you take another person's milk, just like taking another person's blood, there are couple of complications that can happen. So you can say there's a risk of HIV that can happen, but if it's a close friend or a family member, we have to explain the risks to them as a medical person. And if they are willing to take that risk, then I would say it's okay. So our role is actually, we can say it's fine, but from our perspective now, it's not like we are checking the breast milk for infection. No. So before we kind of give our official seal and approval, but we have to say it's definitely it's a very good thing. And it's kind of there in our culture as well. So, but only just explain the risk factor so that, later on they don't, come and tell something has happened. Let them know the risk if they are willing to take the risk. And in that case, I think it is safer, just like when you're giving donor breast milk, get the informed written consent if it's something that is happening within the hospital. If it is happening at home, you can just write it down, I guess. But I think it is acceptable for them to do that while the mother is sort of, correcting her technique and getting ready. I also wanted to just add one more thing, Nimesha. To I think what I think Dr. Sathika and Prof. Geeta both mentioned this. Dr. Sathika said, despite having the 6 months leave, some people have to go in 4 months, which is true. And some people like us in the university get only 4 months also. So in such situations, what I wanted to add is, sometimes because of the mother's working arrangement, she may have to work far from home. So expressing enough milk may not be easy. If she is away from home for a long time and trying to achieve 6 months of exclusive breastfeeding might, because in people's minds, it is some sort of milk to be given for 6 months, which is not at all right. So if it is breast milk, yes, we should go for 6 months. But if we are struggling to achieve adequate express breast milk because maybe of financial problems, people don't want to take the half-pay leave, even though they have it. So because of that, they may choose to go to work. In such situations, the negotiation can be, even though the weight is okay, wait until the 4 months are completed. But after that, if they are finding it difficult and if they are far away from home and there are going to be challenges expressing adequate breast milk for this baby, you have to think about starting complementary feeding. Because if you don't do it, what will happen is the mothers will go for formula feeding, which is a much worse option. That is what I wanted to add. So that is
Thank you very much.
What Sathika mentioned as well. Because I think we have to listen to the parents. We can't just be dogmatic and, just tell what we feel and try to come to a solution halfway, which does not involve formula feeding.
Yes, yes.
So individualize the solution.
Yes,
Is what I wanted to say.
Yeah, thank you very much, madam. So I can give like 1 minute for the participants to ask any questions if there are any. I think we tried our best to answer most of the questions which appeared in the chat. You can use any language that you like when you want to talk. Okay. So in the meanwhile, let me thank all our resource persons today for sharing their valuable knowledge and experiences with us. I don't think what we have discussed today, you can read it in a book and, get an insight about these day-to-day, experiences that they have gathered and they have shared with us today, and which have been really valuable. And also a big thank goes to the wonderful participants who had been asking lots and lots of questions and had been quite stimulating to conduct this meeting today. So if there are no any other questions, let me thank all of you once again on behalf of Sri Lanka College of Paediatricians. And let's work towards improving the breastfeeding rates in our country, hoping that we will create a beautiful childhood for our nation. Thank you very much once again.
Thank you. Thank you, everyone.
Thank you.
Thank you.